So it is my absolute pleasure to introduce now Dr. Allison Vidimos. She's so well known in her field. Every time I go to a meeting and run into somebody, everyone knows Dr. Vidimos. She's trained them, she's tested them, she's done it all. And is a hero to me as one of our pioneering women in medicine. So she is the chairman of our Department of Dermatology. She's the vice chairman of the Dermatology and Plastic Surgery Institute. She's a professor of dermatology, of course, at the Cleveland Clinic Lerner College of Medicine. She's always a teacher, has been program director of the Micrographic Surgery and Dermatologic Oncology Fellowship, and she really prides herself in education, and I've been a part of that, so that's been fun. She's a diplomat of the National Board of Medical Examiners and the American Board of Dermatology. You just can't be more accomplished or qualified for this. So it is our absolute pleasure, and thank you so much for joining us tonight. So Dr. Vidimos will be talking about shared decision-making in treating non-melanoma skin cancers.
Thank you, Pauline, for that very kind introduction. It's a pleasure to speak with you all tonight on something that's near and dear to my heart. I am one of 9 fellowship-trained, board-certified Mohs surgeons at the Cleveland Clinic, and we have a very busy skin cancer practice. And I'm going to share some of our treatment options with you tonight. Let's see. Next. So, as has already been discussed, skin cancer is the most common type of cancer in the world. 1 in 5 Americans will develop one skin cancer by the age of 70. More than 2 people die of skin cancer in the United States every hour. Having 5 or more sunburns doubles your risk for melanoma, which we're not really talking at length about tonight, but I wanted to mention that as well. When detected early, the 5-year survival rate for melanoma, fortunately, is 99%. And for our basal and squamous cell skin cancer is well over 90%. The diagnosis and treatment of non-melanoma skin cancers in the U.S. increased almost 80% in a 20-year time span between 1994 and 2014, and continues to rise. And as previously mentioned, the main factor in causing these skin cancers is ultraviolet radiation from the sun. Basal cell carcinoma is the most common form of skin cancer, followed by squamous cell carcinomas. And the ratio of these is about 20-1 in general, but when patients become immunosuppressed, such as from an organ transplant, this ratio will actually flip. As previously mentioned, more than 15,000 people die of squamous cell carcinoma every year, which is more than twice as many as from melanoma. So this is an epidemic in the United States, and our goal in teaching you this information tonight is that you'll be aware of what these skin cancers look like and will come in early, and also identify them on your family and friends. More than 5,400 people worldwide die of non-melanoma skin cancer every month. As I previously mentioned, organ transplant patients have an increased risk of squamous cell carcinoma about 100 times the general population. And as previously mentioned by LB, the incidence rates of Merkel cell carcinoma, which is rare, fortunately, is also increasing. Why the rapid increase in these skin cancers? Sun exposure habits have been mentioned, prevalence of indoor tanning, the ozone layer depletion also plays a role in addition to the aging population. The impact of indoor tanning is really important to be aware of. Currently, tanning by minors is banned in 19 states. Ohio is working on this as well. People who first use a tanning bed before age 35 increase their risk for melanoma by 75%. And remember this fact, more people develop skin cancer because of tanning than develop lung cancer because of smoking. So this is really avoidable as far as the damage done by the indoor tanning beds. A single tanning bed session increases the risk of squamous cell carcinoma by 67% and basal cell carcinoma by 29%. As previously mentioned, ultraviolet radiation is a carcinogen. X-rays can also play a role, and that's why we track X-ray exposure through CAT scans and Panorex, dental films, etc. Chemicals can also play a role, such as arsenic and coal tars. Patients can also develop skin cancers in long-standing ulcers. They're called marginal ulcers from a burn or an inflammatory process. I've already mentioned immunosuppression and organ transplant patients that can increase the risk of skin cancers. HPV, human papillomavirus, certain types are prone to causing skin cancer. And specifically, we see these on the face as well as around the nails. And Dr. Arberson very nicely covered inherited diseases that can also put patients at increased risk for skin cancer. The Fitzpatrick skin type scale is something to keep in mind. As he mentioned, even though you might have type 6, which is very dark skin, African-American skin, you still can get skin cancer. So we rate from 1 to 6, 1 being patients who can never tan. 2, I'm a 2, I can tan if I merge freckles, but patients who have type 6 and 5 skin very rarely burn, but they still can get enough sun damage to cause skin cancer. So in summary, the risk factors for basal and squamous cell carcinoma: radiation therapy, light hair, eye, and skin color, so blondes and redheads, chronic wounds, immunosuppression, ultraviolet light, the human papillomavirus infection, phototherapy. So some patients will have skin diseases that warrant treatment with light therapy, and that can, on long-term use, also put you at risk for skin cancer. Genetic syndromes, as mentioned, and again, artificial indoor tanning. Basal cell carcinoma, I said, is number 1. We see over 2 million cases in the United States. Unfortunately, these are usually not problematic, but they can become problematic if they're neglected. Metastatic basal cell carcinoma means that the tumor spreads to the lymph nodes or to the lung or other organs. This generally happens with very large tumors. So a very large 25 centimeter tumor has a 95% risk of spreading versus a 3 centimeter tumor, which has less than a 2% chance of spreading. So again, the importance of catching these early and treating them appropriately is really very important. Locally advanced basal cell carcinomas, this is a loosely used term. These are not, these are tumors that really have been neglected but have not spread anywhere. And they may involve areas that are important for function and cosmesis. So patients will eventually come in to have them treated. The important thing to know in this evening is that we are proud to manage our patients, whether they're melanoma or non-melanoma patients, in a multidisciplinary fashion. So when a patient comes in with a very advanced tumor, they have the best minds from medical oncology, radiation oncology, pathology, dermatology, and surgery to put their thoughts together on how best to treat that very difficult tumor. These are examples of what basal cells can look like. Basal cell carcinomas, they can be ulcerated. This is a very small one on the tip of the nose. And patients will say, you know, when I towel off, this area bleeds and then it heals and then it bleeds and then it heals. Those are lesions that really need to be biopsied. This is a classic look of a pearly border with an ulcer in the center. This is a patient with darker skin who has a basal cell carcinoma. You can see it's pearly and shiny, but it does have pigment in it, which can make it sometimes look like a melanoma. And then a very fair-skinned patient here with just a very tiny ulcerated basal cell carcinoma on the bridge of her nose. Treatment options for basal cell carcinoma may be surgical. Radiation therapy can be used, field therapies can be used, and these are generally done for very superficial basal cell carcinomas. PDT was mentioned, photodynamic therapy. Imiquimod is an immune response modifier cream that can be applied to both actinic keratoses, the precancers, as well as superficial basal cell carcinomas. And 5-fluorouracil is a topical chemotherapy cream that can also be used for just the superficial tumors. For locally advanced or metastatic basal cell carcinomas, we were fortunate 10 years ago to get an oral medication called a hedgehog pathway inhibitor called vismodegib. And 3 years later, sunitinib was FDA approved for treating these locally advanced and metastatic basal cell carcinomas. And more recently, in 2021, cemiplimab, which you'll hear about from Dr. Geiger, is a PD-1 inhibitor immunotherapy that can be used for tumors that don't respond or stop responding to the hedgehog inhibitors. Squamous cell carcinoma is the second most common skin cancer. There's over 8,000 deaths a year. The overall mortality rate is 1 to 3%, a little higher than with basal cell carcinoma. And again, we're seeing more of these because there is an increased focus on skin cancer screening. So patients are coming in early because of these education efforts. Fortunately, most patients with cutaneous squamous cell carcinoma have localized low-risk disease that can be treated with surgical resection with a very high cure rate, over 90%, and with a average risk of nodal miss of up to 6%. So again, this is fairly rare if the tumors are caught early and treated appropriately. Just some examples. This is a small squamous cell carcinoma, somewhat innocuous looking, but this ended up traveling around nerves through her eye socket. So these can look very innocuous, but can be very aggressive in behavior, hence the need for early diagnosis and treatment. A more extensive squamous cell carcinoma on the scalp of a man who had a chronic wound there, one by the eye that was thought to be a cyst. The lip and the helix of the ear are very common sites for squamous cell carcinoma, and these locations can have tumors that are a little bit more aggressive in behavior and have a higher risk of spreading to the lymph nodes. So again, those need to be diagnosed and treated very early. Similar treatment array, surgical, radiation therapy, topical therapies, mainly for the in situ squamous cell carcinomas, which means they're limited to the upper layer of the skin. And Dr. Geiger will talk about PD-1 inhibitors for treatment of more advanced squamous cell carcinomas. These are cure rates at 5 years for basal and squamous cell carcinomas. So you can see most of them are at or above 90%. And we have discussions with patients about what the best option is for their skin cancer by its size and location. I wanted to discuss the difference between how a routine pathology lab checks margins when we ask them if a skin cancer is out. And in general, they do what's called bread loafing, which means if you think of what we give them as a loaf of bread, they pull out every fifth piece and look at the crust to see if the tumor has busted through the crust. Whereas with Mohs surgery, we're checking every single piece of bread in that loaf. And that's why we use this for the higher risk tumors, because we can check 100% of the surgical margin and maximize preservation of normal tissue. This is the Mohs technique where we basically have kind of a pie piece, and we flatten this so that the outer edge, the epidermal edge, is in the same plane as the dermis and the fat. So when we run a knife through this tissue, we basically get 100% of that edge. I tell patients, think of it as the tumor being a pie, the filling is the tumor, and we're checking the whole crust of the pie to make sure the filling hasn't busted through the crust. I'll walk through the Mohs surgery procedure with some pictures. So we identified this as a basal cell carcinoma on this patient's temple. The skin is painted with a surgical soap, and we've marked where we think the edges are with ink. We curette with a tool that gives us a feel for what's left of the skin cancer because it's kind of soft in consistency, so it gently scrapes away. And then we take a small margin around that scraped area. We divide the tissue into either 2 or 4 or more pieces, and it's placed on a map and oriented. The specimens are numbered and dyed. So there's blue and red and green and black dye put on these pieces of tissue so that when we look at the tissue under the microscope, I know exactly where I am around the circumference of that wound. We stain the tissue in the lab, and then the Mohs surgeon and the Mohs surgeon is the pathologist. That's the definition of Mohs surgery, is that the individual removing the tissue is also the pathologist interpreting the tissue. And then we see if there's any tumor at any of the edges, and if there is, we take more. So this is tumor here on this piece, and we can go back to the patient at this spot only and take another sample until the tumor is clear. And then once the tumor is clear, sometimes we let the wounds heal on their own. Sometimes we close the wound side to side. We can do local flaps, full or split thickness skin grafts. Sometimes they're very extensive wounds that are repaired by our facial plastics, or oculoplastics surgeon colleagues. And we also have the option, if we want to monitor a wound bed for tumor recurrence, we will have an anaplastologist make a prosthesis, meaning a nose or an ear that the patient can wear for at least a year. And then at a year, reconstruction can be considered if there's no tumor recurrence. So how do we decide which of the treatments to choose? We discuss all the options with our patients. We decide by the type of skin cancer, the number of skin cancers, risk factors related to the cause of the tumor. Is there a genetic syndrome going on, for example? Are they immunosuppressed due to a disease or an organ transplant? The size of the skin cancer, where it's located, how long has it been there? The character of the tumor margins, is it a very clear margin or is it an ill-defined margin? What is the pattern of growth under the microscope? Has it been treated before? Are there symptoms associated with it, such as pain or loss of sensation? We also grade the risk of the tumor behavior by where it is. So high risk sites are in blue here on the face, the genitalia, the hands and feet. Intermediate risk areas are in blue here, again, the scalp, the lateral cheeks, the neck, and the shins. And then lower risk areas are the rest of the body. And we actually have an app on our phone where we plug this information in, the tumor type, the size, the location, any medical factors that come into play. And it basically gives us a number that tells us that Mohs surgery is appropriate or not. The age and cosmetic concerns of the patient are also important. Any comorbidities, what other medical issues they may have, what medications they're on, if they have implantable devices, are they a smoker, do they need preoperative imaging to ascertain how extensive the tumor is. And again, we frequently call on our colleagues to help us with these decisions. Things the patients, as you as a patient should ask, what happens if I do nothing? What are my treatment options? What type of surgery will be done? Will my age, health, or other factors affect my choices? How will I know if the treatment's working? What are my options if the treatment doesn't work? Do I need treatment right away? Where will I be treated? Is it an outpatient surgery or an operating room procedure? What are the short and long-term side effects of the treatment or potential complications of the treatment? Will I need reconstructive surgery? Where there'll be activity restrictions after surgery? Am I eligible for a clinical trial? What support services are available to me? And how often will I need follow-up visits? And Dr. Arbesman nicely covered that. I'm going to walk through a quick couple cases just to show you. This is a 80-year-old woman with an infiltrative basal cell carcinoma on her upper lip, which was quite extensive. It took us 4 stages to clear, and I repaired this with a flap, and she really healed quite well. More extensive basal cell carcinoma on the nose that did recur after an outside non-Mohs excision. And we discussed her options after imaging this tumor. She did not want surgery, and I used a hedgehog inhibitor on her for 9 months. And before starting it, I debulked this so there was less tumor for the medication to tackle. And we've actually studied this on a molecular level and shown that surgically manipulating these tumors makes them more sensitive to the vismodegib. So that's a very positive development. Another man with a basal cell carcinoma, which was full thickness through his eyelid. He declined surgery. I debulked this with a curette and put him on the vismodegib for 1 year. And this is him 10 months into the treatment with a very nice functional and cosmetic result. Side effects from these medications are not small. Muscle spasms, alopecia, and change in taste are the most common. We start patients on 5 days a week instead of 7 in my practice so that these side effects are slower to come on and less severe, and makes the patient less apt to want to stop the medication due to the side effects. My last case is a 104-year-old woman, my oldest Mohs patient, who came in, and this was her first skin cancer, and she walked into the appointment and she was angry. She said, "Why do I have this?" And I said, "It's because you're 104. Most people get these in their 50s and 60s. And she was a golfer, and she really wanted this off. It was interfering with her golf game. So we did do Mohs surgery on her and cleared this after 2 layers. I did a flap repair. She healed very well at suture removal. And when she was done, she said, "Now, when can I play golf again?" And she lived 2 more years without that skin cancer. So you're never too old to get these treated. Thank you very much for your kind attention. Keep calm and wear your sunscreen. Thank you.
Thank you very much, Dr. Vidamos. That was never eat while you're listening to a Dr. Vidamos talk. But some amazing stories as always. Learned a lot about treatment, and I see a bunch of questions, so get ready, speakers.